Okay. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Assalamu alaikum. My name is Ahmed Adlan, and I am a cardiology registrar working in the West Midlands, and I am very pleased to be able to present to you today part 2 of my talk on evidence-based medicine publications and critical appraisal. And this is going to be the first time that we have done a live journal club. This project is in collaboration with the SJDA UK Personal Professional Development Project. And today I am very pleased to be able to have the opportunity to demonstrate with a live journal club. In the last talk, I went through evidence-based medicine and how to critically appraise a paper. And I also introduced the idea of a journal club and how you would go about performing it and what it involves. So while we're waiting for more people to join, I am just going to do a couple of brief slides on publications because I did not have a chance to talk about this in the last talk. So publications are very important. They're very good for your CV, and they're very good in terms of a very good skill to have to be able to publish. And really, there are many different types of publications, and perhaps the most impactful of publications are the original research articles, and they include pieces of work which are original, which is sort of new research when you've done a research project and you want to write it up and you want to share it with the rest of the scientific community. This on all sorts of application forms, whether it's specialty applications or consultant job applications, having an original research article is the highest level really of publication. Particularly being a first author. So it's a very useful tool to have. The second type of research article or the second type of publication is a review article. And review articles are of two main types. One is a systematic review, and the second is a narrative review. So with a systematic review, this is basically you're going through a literature review of what's been published before, and you are searching other articles that have been published. You're searching basically original research articles. And what you do, you start off with a problem that you want to try to answer based on the evidence that's available. So you collect a whole host of articles and you go through them and you come up with some sort of conclusion based on the results of your literature review. The reason it's systematic is because you have a very systematic approach to how you collect the articles, where you look for them, what articles you include, what articles you exclude, and that's why it's called systematic. Now, if you've done a systematic review, then based on what data you have available, you can take data from the original articles themselves and the original publications, and sometimes you can do an analysis of combining lots of other randomized controlled trials, for example. And this is called a meta-analysis. And a meta-analysis is a very high form of publication. And in fact, systematic reviews and meta-analyses are actually included as original articles, because you've brought something new by combining all the evidence that's available. When you do a systematic review, again, there are two main parts to it. The first part is that you critique the evidence and you see what is the quality of evidence available, what type of studies are available, what type of evidence is there, how many studies are there, are they randomized controlled trials, are they biased, are they observational studies? So the first part is grading the evidence, and then the second part is actually answering the question. The reason that's important is because sometimes you have a question, you do a literature review, and you only have one study, which is an observational study, which is biased. with a small number of patients. So already, when you grade the level of evidence, you know that actually there's very poor quality of evidence. So whatever the answer is from that study, it's not going to be very impactful. And that's something very important. On the other hand, if you have 100 randomized controlled trials with 10,000 patients altogether, then actually the quality of evidence is very high, and whatever the conclusion is of your analysis, your meta-analysis or your systematic review, you can rely on it more so. So that's the systematic review. A narrative review involves a bit like having a discussion, basically, and you choose a topic and you just talk through, in fact it's quite informal. The structure can be very varied depending on what type of review you want to write about, and you can literally use your imagination. And what you do is you summarize not necessarily all the evidence, but what you think is relevant evidence, and write a sort of a narrative writing about a particular topic. So those are the review articles. Then you can have an editorial. Usually editorials, they are picked by the journal. Usually they choose people who are eminent in that field to write an editorial. And an editorial is really like a commentary almost of an original article. So what usually happens when you publish in a journal, then what happens is the editor may select one or two or three of the publications which they think are the most impactful, and they will write an editorial on them where they describe the evidence or study, the new study, and give some sort of flavor of what they think, how they think it should be interpreted. Then another type of publication is a letter to the editor. Now, letters to the editor are very useful forms of communication, and they count as a publication, and it's a relatively easier way to get something published. So if you've done a small project, it may not be big enough to put in as an original research article, and you may want to just summarize that. You have less words to play with, and you're able to publish that as a letter to the editor. It's very useful, very good way to start off. And then you have the case reports, which you pick a case that you find interesting, something that can be relatively rare, or something that is it can be something that is common, but the message has to come across that there's something that people can take from it and learn from that particular case, and that's the key to case reports. There are some journals available that only publish case reports, and case reports are a very good way to start off writing process and publishing. Most people, when they want to learn how to publish, they'll start off with case reports. Then you have other types of publications, which if you look at many different journals, they'll have different types of quizzes or images, or you can even publish educational modules. For example, on Medscape, they have educational modules. Another type of publication is an abstract. So when you've submitted a paper, or you've submitted something to be considered for a poster or at a conference, often that will include an abstract publication, which again, it's very good. Very, very briefly, how to get started with publications. So the first thing I would say is it's best to try to collaborate with someone who is experienced in publishing. So, for example, your registrar or consultant, get to work with them, because they will be able to teach you how to go about writing. So, for example, where I learned how to write was I did a draft, and then I sat down with the registrar. He went through it and he corrected it, and I was able to see his corrections and see how you write in a scientific manner. And similarly, when you work with consultants as well, they will edit your work, and when they edit it, you're able to learn about how to publish and how to write scientifically. The next thing is to think about choosing a suitable journal. So think about your audience. So think about who it is that you want to communicate with in your publication. Is it a general medical publication? Is it for the general surgical community? Or is it something very specific, a small group of people that you want to communicate your work to? That's important, because if you have a good piece of work, but if you submit it to the wrong journal, then you may not get the publication, and it wastes quite a bit of time. So that's something very important. Once you've chosen your journal, go to their website, look at the author's instructions, or they usually have a section for authors, and go through that and use that as a template and a format to how to structure your manuscript and what sort of publications they accept, and try to tailor your publication towards that particular journal. My advice is to download a similar article from that journal and have a look at how they format it and how it's laid out, to help guide you when you're writing your manuscript. The other thing is, with scientific communication, try to tell a story. You've done some, whether it's original work or a narrative review, try to build in a story of what it is you want to try to communicate, what it is you want to say in your manuscript. What is your publication? What is your publication saying? What are the key points? And try to tell that story in a nice manner. My other bit of advice is, try to structure your article before you go into the details. Before you focus in on the details of specific points within your article, try to think about the layout and how you're going to structure your article. What are your subheadings, etc. Remember to reference. So anything really, any statement that you write in your article, your manuscript, should be backed up with references. And the last thing to say about publications, is to be persistent. So don't give up. So many times we've submitted manuscripts and you get rejection after rejection after rejection. Don't give up. Be persistent. Keep trying. Improve your manuscript. Adjust it. Think about why it is it didn't get through. So that's basically on publications. So I've got a question from Aya Abdullah. So the question is, should it be a specific, and there's so many researches done on it to be presented in conference? I'm not sure exactly what that refers to. If you could just elaborate on that question. Do you mean about abstracts? I will carry on for the time being, but if you could just elaborate on that question, I will try to answer it for you. Okay. So I'm going to now present to you a live journal club, and this is a publication that I've chosen. So you're talking about an abstract. Yeah, so abstract, if you're trying to present at a conference with an abstract, yes. So when you submit your work for consideration at a conference, they don't normally ask for an abstract, and that abstract usually has a limited word count. So what you want to do is try to really summarize the main points of your study, and what's been done before, why is it important, why is it relevant, and what did you do, what did you find, and why is it important? And sometimes you can put in a figure or a table, but it depends on the particular conference. So even if there have been many other studies out there that have done work, similar work, you'll still find that actually it's useful to present it at a conference, because sometimes they will accept your work, particularly if your project is specific to your hospital. But again, if there's many abstracts on the same thing, you need to have something that shows that your work is different. Okay, so I hope I've answered that question. So in terms of this paper is that Rivaroxaban with or without aspirin in stable cardiovascular disease, and it was published in the New England Journal of Medicine just about 2 months ago. So it's a very recent article. It's also called the Compass trial, and it's called stands for cardiovascular outcomes for people using anticoagulation strategies. And it was actually presented at the ESC, which is the European Society of Cardiology conference, earlier this year in the summer. And the reason I chose this article for the live journal club is because no matter what sort of field you're in, you're going to be dealing with patients who are on anticoagulants, whether you're in medical field, whether you're in cardiology, whether you're in surgical specialty and you have patients who are due for operations and they're taking anticoagulants and they're taking aspirin, or whether you're a neurosurgeon dealing with bleeding complications, or whether you're a gastroenterologist having to deal with patients who've got GI bleeds on anticoagulation. So I think it's something which is quite widespread, and as you were seeing more of these drugs, Rivaroxaban and some of the other oral anticoagulant agents, it's something that more and more is becoming more common. Even if you're in general practice, you may have patients who are taking some of these medications. So a bit of background about this topic. So cardiovascular disease is very prevalent, and in fact, alarmingly, it accounts for about a quarter of all deaths in the UK. So 1 in 4 deaths in the UK are caused by cardiovascular disease. It's really it's really amazing to think that. And in 2015, it was noted that almost 160,000 deaths were caused by cardiovascular disease. So it's a very common problem. And with the aging population, it's only going to become more and more common in the future. What studies have shown is that if you've got cardiovascular disease, around 5 to 10% of patients have a recurrent cardiovascular event, whether it be a stroke or a heart attack. It's 1 in 10 patients with cardiovascular disease have a recurrent event. We have options to try to minimize that and to reduce the risk of recurrence. And one of the sort of earlier treatments has been aspirin, and aspirin is pretty good at preventing cardiovascular events. In one study, it showed around 20% fewer cardiovascular events and around 10% less deaths. So it's a pretty good treatment, and we all see patients who've got cardiovascular disease or peripheral vascular disease or cerebrovascular disease who take aspirin. Now, there was a study that was published a few years ago where they looked at Rivaroxaban. Rivaroxaban is a non-vitamin K oral anticoagulant, a NOAC, or a direct oral anticoagulant, DOAC, and it works as a factor Xa inhibitor. And it has a number of licenses, and the main license for Rivaroxaban is in stroke prevention in atrial fibrillation. It's also licensed for use in prevention and treatment of thromboembolic disease. However, in 2012, a study was performed where they added in Rivaroxaban at a low dose, 2.5 milligrams twice daily, to patients who had an acute coronary syndrome and who were already taking aspirin and another antiplatelet. And what they found, interestingly, was that the Rivaroxaban at the low dose reduced mortality, but at the same time, they found an increase in bleeding. And this is the results of the study here. It's called the Atlas ACS2 TIMI51 study in 2012. And if you look here, you have death from cardiovascular causes, myocardial infarction or stroke, and you have the time in days. And what you can see is that there was a significant reduction in death from cardiovascular causes, MI or stroke, in patients who were taking the Rivaroxaban 2.5 milligrams twice daily dose. This was statistically significant, and it was around a 16% reduction. But unfortunately, they found that there was an increased risk of bleeding, which is unsurprisingly, if you give aspirin, a second antiplatelet, and Rivaroxaban, it's not surprising that you get an increased bleeding risk. So based on that study, the hypothesis is that in patients with stable atherosclerotic vascular disease, if you take Rivaroxaban with aspirin, or even Rivaroxaban alone, the hypothesis is that it would be more effective than just taking aspirin alone in preventing recurrent cardiovascular events. And at the same time, it is thought to have an acceptable safety, and that's what they wanted to test. So how did they design this study? So it's a multi-center, double-blind, double-dummy, randomized controlled trial. It ran in over 30 countries, in over 600 centers. And this is this table here demonstrates the design. This is called a 3x2 factorial design. And I'm going to explain a little bit about this design in the next slide. But essentially, you've got 3 treatments, and they also looked at the use of pantoprazole to see whether that made any difference. So, got a question here: what is a double dummy? Okay, that's a very good question. So, what double dummy means that in a randomized controlled trial, you have a patient taking a new drug and a patient taking the old drug, and some patients not taking any drug. Okay, so you can have someone who's taking a drug, someone who's not taking a drug. Now, if you randomize a patient to have a placebo, to not take a drug, then if they're not taking the drug, you give them some sort of what we call a dummy drug, something which looks like it. So basically, the drugs that the patients are given, they all look the same. So both the patients, they can't tell the difference between what the drugs are. They just know they're taking 3 pills. They don't know which ones are which. So some of those pills may be real, some of those pills may be placebo, but the patient doesn't know, and so that would be a single dummy. If both the patient and the physician doing the study can't tell the difference between which is the study drug or which is the placebo, then that's called a double dummy. So I don't know, does that answer the question? So I'm just there's a little bit of a delay there, so I'm just gonna carry on, but if you can tell me if you'd like me to explain that again, then I'm happy to explain that again. Now, so what they did was they essentially were testing 3 treatments. So they were testing, in one group, they were given aspirin 100 milligrams once daily. Now, 100 milligrams is a bit of a strange dose to people who are used to working in the UK, where we use 75 milligrams once daily. But around the world, there are various dosages of aspirin. So they've stuck for something which is 100 milligrams. So in one group, they were given 100 milligrams of aspirin. In another group, they were given aspirin 100 milligrams plus Rivaroxaban 2.5 milligrams twice daily, which is a very low dose. And that was the same dose that was used in the Atlas study in acute coronary syndrome. And the third treatment is Rivaroxaban 5 milligrams twice daily without aspirin. So those are the three main groups that they were testing. Which is better? Aspirin 100 milligrams, aspirin 100 plus Rivaroxaban 2.5 twice daily, or Rivaroxaban 5 milligrams twice daily without aspirin. And the second thing they looked at was what is the effect of taking pantoprazole? So does the pantoprazole make a difference or not? So that's why it's called a 3x2 factorial design. So what they did was they had a run-in phase where they gave aspirin and either a placebo or Rivaroxaban. Okay, so this is where the dummy comes into it, for 30 days. And then they switched them over to one of these groups here. So this is what. So this, so some of the patients went on to have a coronary artery bypass graft, and in those patients, the run-in phase was between 4 to 14 days. So I've got a question here from Maha. Does Rivaroxaban have an antidote? Yes, it does have an antidote. It's a factor 10A antidote that has been developed. However, it's not been licensed in the UK, so it's not available at the moment. But it's been shown to be quite effective, and there have been some studies that have demonstrated that it has a very potent effect and quite a quick acting effect. Okay, so they followed these patients up for the first month, and then 6 months, and then at 6-month intervals for 3 to 4 years. Okay, now they had some inclusion criteria and some exclusion criteria, like you would have in all studies, really. And the main inclusion criteria was patients with stable atherosclerotic vascular disease, which they sort of defined as having coronary artery disease, peripheral artery disease, or both. That was the first thing. The second thing was that if patients were under the age of 65, they needed to have documented atherosclerosis involving at least 2 vascular beds. So, for example, heart, brain, renal, for example. Or they had to have 2 additional risk factors, and the risk factors they were interested in were being a smoker, diabetic, some degree of renal impairment with a GFR, an estimated GFR of less than 60 mils per minute, heart failure, or a non-lacunar ischemic stroke more than a month before they were included into the study. So really, they were trying to get patients who were stable and had documented atherosclerotic vascular disease. In terms of the exclusion criteria, they ruled out any patients who had a high bleeding risk, which is quite sensible. They also excluded patients who've had a recent stroke or any previous hemorrhagic stroke or any recent lacunar stroke. They also excluded patients who had severe heart failure, significant renal impairment with an estimated GFR of less than 15, patients who were already on dual antiplatelet therapy, so in other words, they were already taking aspirin and clopidogrel, for example, any patients who were already taking anticoagulation or any other antithrombotic agents, and also they excluded patients who had non-cardiovascular conditions that were associated with a poor prognosis. terms of the ethics, they got ethical approval appropriately, and they obtained written consent from every patient. Interestingly, the study was sponsored by Bayer, which is a pharmaceutical company that produces or manufactures Rivaroxaban. So the outcomes. Now the outcomes, they were looking at two major outcomes really: efficacy, and in a lot of these studies, that's something important you look for: efficacy. How well does the treatment work? And then they also looked at safety. How safe is the treatment? And in terms of the efficacy, they looked, as a primary outcome, they looked at a composite, which means they took together the number of cardiovascular deaths, strokes, or MI. So that was the primary endpoint that they were looking for. The secondary endpoints, there were a couple of these secondary endpoints, which included ischemic stroke, MI, acute limb ischemia, or coronary heart disease death. And another composite endpoint of ischemic stroke, MI, acute limb ischemia, or cardiovascular death, or they looked at death from any cause. For the safety outcomes, they looked at major bleeding, and they defined major bleeding as a fatal bleed, or a symptomatic bleed into a critical organ, or a symptomatic bleed into a surgical site that required reoperation, or a bleed that required hospitalization. And then they calculated something called, or they included something called the net clinical benefit. So what they were trying to look at was what was the overall benefit of the treatment in terms of how efficacious it was and how safe it was. So, for example, they looked at cardiovascular death, MI, stroke, fatal bleeding, and symptomatic bleeding into a critical organ to work out the net clinical benefit. Regarding the statistics, they planned to recruit 27,400 patients, and they were looking at 2,200 primary efficacy outcomes. So basically what that means is that their plan was to recruit 27,000 patients, and they were planning to wait until they got 2,200 events, basically. And that was based on a calculation that they've done based on a 90% power to detect a 20% lower risk in the primary outcome. So they also had something called a pre-specified stopping guideline. So what they did was they sat down before the study and they decided that if we see this much difference in benefit or this much, signs of harm, we were going to stop the study early. The statistics was planned to be done as an intention to treat analysis. So intention to treat, so you have two types of analysis. You have an intention to treat and a per protocol analysis. And the difference between those is that with intention to treat, you say, at the start of the study, I've randomized this patient into this arm. And it may well be that that patient did not complete the study in that arm. So they may have, sometimes patients switch over from one arm of a randomized controlled trial to another. So typically, for example, you may have somebody who was started on a drug therapy and they weren't able to tolerate that because they had side effects. So then they had to come off that drug completely. Now, what do you do with that patient? Do you include that patient on, which arm do you include them on? Do you include them on the arm that they were originally on or the arm that they actually were on? So do you analyze it based on what your intention to treat was, which would be, we intended to treat this patient with this drug, and that's how we're going to analyze them, and that's what an intention to treat analysis is. Or you say, actually, I'm going to look at what treatment they actually received, and do analysis based on what the patient actually took. That's a per protocol analysis. The stratified, they did a stratified Cox proportional hazard ratio was their main statistical analysis, which is appropriate for this type of study, and they looked at 95% confidence intervals. So in terms of the results, so the study enrolled 27,395 patients, so they're only 5 away from their target of 27,400, so they pretty much achieved their target. And they enrolled patients from March 2013 to May 2016, so roughly 3 years, just over 3 years. Interestingly, this study was stopped in February in 2017, earlier this year, after the first interim analysis, where they only had 50% of the planned events. And they stopped the study. And I'll explain to you the reason why they stopped the study. The first thing to note in terms of this table shows the baseline characteristics. So you've got the Rivaroxaban plus aspirin group here, where you've got just over 9,000. And the Rivaroxaban alone, this was the 5 milligrams twice daily, and then patients with aspirin alone. You can see that their patients were around the age of 70, just under 70 on average. And the first thing to say really about this table is that they actually, fortunately, they randomized the patients pretty well. There were no major differences in any of these parameters when they did the analysis. So they're quite lucky when they randomized the patients. Sometimes when you randomize patients, you may be unlucky. So the idea of randomizing is that you should expect this sort of thing where you get the same number of same type of patients in each group. Sometimes you're unlucky and you don't get it being the same. So they were predominantly male. So you can see around 20% were female. The BMI was around 28. Their blood pressure was within normal limits. Their cholesterol was around 4, just over 4. There's about 20% smokers, high proportion of hypertension, over a third were diabetic. Very, very small number of patients had a previous stroke, and quite a large number of patients, nearly 2/3 of patients had a previous MI, and about a fifth of patients had a history of heart failure. So these patients, you probably would say that they are high risk patients, cardiovascular risk. Around 90% of patients had coronary artery disease. Around 30% had peripheral artery disease. Most patients, about 60%, were white. Only 1% of patients were black. And as you can see in terms of the medications, around 70% were on an ACE inhibitor or an angiotensin receptor blocker. 70% were on a beta blocker. 90% were on a statin, and about a third were already taking a proton pump inhibitor. And this is the main primary outcome. So what you have here is the cumulative risk of cardiovascular death, stroke, or MI on the y-axis, and on the x-axis you have year 1, year 2, year 3. And these are the 3 lines. Okay, so this is what you have. The black line here at the bottom is the Rivaroxaban and aspirin group. Then you have the blue line, which is the Rivaroxaban alone. And then you have the red line, which is patients who are taking aspirin alone. So what you can see is that patients who were taking aspirin alone had the highest rates or risk of cardiovascular death, stroke, or MI. And patients who had the Rivaroxaban 2.5 milligrams twice daily and aspirin, they had the lowest risk. And you can see this on the right-hand side here. You can see that I've just zoomed in on that to show that there was a significant difference between the aspirin group and the patients taking Rivaroxaban and aspirin. And I've highlighted it here. The p-value was less than 0.001, and the hazard ratio was 0.76, so there was a 24% risk reduction in the primary outcome of cardiovascular death, stroke, or MI in patients taking Rivaroxaban in addition to the aspirin. What about the patients with comparison between the aspirin and the Rivaroxaban alone? Well, unfortunately, this didn't. They were lower. They did have a lower risk, yes, but it wasn't statistically significant. Okay, so this table demonstrates the efficacy outcomes. So what you have is the outcome here on the left-hand side. Then you have the absolute values here in percentage, in number and percentage of outcomes in patients with the Rivaroxaban 2.5 twice daily and aspirin, Rivaroxaban alone, and aspirin alone. And then you have here the hazard ratios with the significant values, and this is for patients with Rivaroxaban plus aspirin versus aspirin, and this is Rivaroxaban alone versus aspirin. So I know this is quite a lot of figures to take in, but I'm just going to focus in on a few important things. So if you look at stroke, there were fewer strokes in the Rivaroxaban and aspirin group compared to patients taking aspirin alone, and that was statistically significant. And the reduction in stroke was actually in ischemic strokes. So there were less ischemic strokes. Hemorrhagic strokes were fewer, but there was no significant difference in hemorrhagic strokes. But there were less ischemic strokes in patients taking aspirin with the 2.5 BD dose of Rivaroxaban. It was quite interesting. The other interesting thing was that if you look at rates of myocardial infarction, there was no significant difference in MI, and that's a bit surprising for me because the initial study, the study in acute coronary syndrome, they did find a reduction in cardiovascular events, and so if we're saying in this study that patients have less cardiovascular death, stroke, or MI, well, we can't really say that the MI, it's not that down to the MI rates being lower. So Maha's asking, is there any role of Plavix here? I think that's a very good point, and I think certainly for patients with cerebrovascular disease and had a previous ischemic stroke, there's evidence for the use of clopidogrel. So I think that would have been quite interesting to look at. Perhaps it might be interesting to look at the difference between aspirin and clopidogrel. Yeah. So then, in terms of the bleeding events and the net clinical benefits, so the important thing here is that patients with Rivaroxaban, in addition to aspirin, they had more major bleeding, and that was statistically significant. And I think that's something which is probably expected if you're taking Rivaroxaban in addition to aspirin. But importantly, you could argue that the fatal bleeding, there was no significant difference in fatal bleeding. Where was the bleeding coming from? Well, it seems to be coming from the GI tract. So there is an increased risk of GI bleeding with the addition of Rivaroxaban to aspirin. GI bleeding is an interesting one because in the Rivaroxaban studies looking at Rivaroxaban in atrial fibrillation, that they found a similar thing. They found that there were increased risk of GI bleeds in the Rivaroxaban group compared to the warfarin group. So again, this study shows that there may be some, although the mechanism is not clear, Rivaroxaban, there seems to be a link with increased GI bleeding with Rivaroxaban. Importantly, the bleeds weren't intracranial. There were no difference in intracranial bleeding. Okay, so this slide basically summarizes one of the tables where they did a subgroup analysis. So sometimes when you do a study, you have a main analysis, and then you can do a subgroup analysis, which basically looks at whether any other factors in your study that seem to give you different messages to your main outcome. So if you take your whole study as a whole, that study gives you a certain answer. You want to look at the subgroups and whether that shows a consistent message within your subgroups, or whether there are any important differences within the subgroups. And I think really to say is that in patients over the age of 75, there doesn't appear to be a difference in that reduction in cardiovascular events, MIs and strokes, cardiovascular death. As you get over the age of 75, that sort of disappears. So that benefit of Rivaroxaban seems to disappear in the older patients, which is quite interesting. There were no gender differences, statistically at least. Interestingly, it looked like Eastern Europe and Asia Pacific, they seem to have more of a benefit compared to North America, South America and Western Europe. Okay, so I was asking, bleeding is the main side effect of Rivaroxaban. What about other side effects? Yes, I think that's a very good question. And in fact, if you look at some of the earlier studies with Rivaroxaban, you will find they categorize a lot of all of the side effects of Rivaroxaban, and that's generally how when you develop a drug, the first trials and studies, they look into side effects, and it's very important to look at the side effects. But really, for the purposes of this study, perhaps the most important and the most relevant side effect to patients is the risk of bleeding, and I think that's one of the major risks with Rivaroxaban, and I think that's why they've not reported any other side effects. They've only reported bleeding. Certainly, in my use, I've not really seen very many side effects of Rivaroxaban apart from bleeding. But there's been a couple of patients who've had some strange side effects. I don't know whether that can be attributed to the Rivaroxaban, but yes, certainly that's a very good question. The interesting thing is that in patients who weighed less than 60 kilos, again, there was no real difference between aspirin and Rivaroxaban, so adding the Rivaroxaban. And I guess that's probably related to the bleeding risk again. I think probably patients who are low body weight, we know that they have a higher risk of bleeding, so perhaps the benefits do not outweigh the risks of the bleeding. Interestingly, if you looked at patients with renal function, renal dysfunction, and those who had normal renal function, there was no difference. Similarly, smoking status, diabetes, hypertension, there was no significant difference. It looked like patients who didn't have coronary artery disease for some reason, they didn't seem to get a benefit, and I think that's quite interesting. I think that probably gives a signal that patients who are really truly high risk patients are more likely to benefit from having Rivaroxaban. And if you've got coronary artery disease, then you're probably going to be at higher risk of a cardiovascular event than a patient who doesn't have coronary artery disease. So if you take that into account, probably that explains that finding there. So in summary, when you look at Rivaroxaban, 2.5 milligrams twice daily in addition to aspirin, when you compare that to aspirin, what the study shows is that there are fewer cardiovascular deaths, strokes, or MIs as a composite. There there are fewer all-cause death, fewer cardiovascular death, fewer strokes, and fewer cardiovascular hospitalizations, but there was no difference in MI or heart failure. There were more major bleeds, but no real difference in fatal bleeds. The gastrointestinal tract was the commonest bleeding site, and overall, adding in Rivaroxaban to aspirin at a low dose seemed to have a lower net clinical benefit. With regards to Rivaroxaban alone versus aspirin alone, so that's the 5 milligrams of Rivaroxaban versus aspirin, what they found is that there were definitely more intracranial bleeds. Statistically significantly more intracranial bleeds. So the conclusion of the authors were that Rivaroxaban 2.5 milligrams twice daily with aspirin is associated with lower rates of the primary outcome, but higher rates of major bleeding versus aspirin alone. There was a net clinical benefit of 20% with Rivaroxaban. Having taken Rivaroxaban 5 milligrams twice alone, there was no difference in the primary outcome, but there were higher rates of bleeding. And they suggest that stopping the study early, in terms of their limitations, were that when you stop a study early, it can overestimate the treatment effect. Some of the other limitations they pointed out was that whether the patients were taking aggressive secondary prevention therapy wasn't specified, and they didn't specifically record the LDL levels. And also they excluded patients who'd had a prior stroke. So Aya has commented that there is a great challenge to find the balance between thrombosis prevention and bleeding risk, and I think that's absolutely right. I really agree with that. I think it's very difficult to do. It's very difficult to do in studies, and it's very difficult to do in patients in real life. So in terms of my personal critique of the paper, I've split it into the strengths on the left and the weaknesses on the right. So I think that the study design was a strength. It was a randomized controlled trial. It was well conducted. It was double blind, and it was a double dummy, and you know they really did perform a good study design. They used the appropriate statistics. They had a large number of patients, which was they performed their power calculations beforehand. It was well written and it was well presented. It was written in the New England Journal of Medicine, and it reads reads very well. In terms of the weaknesses, well, I think for me the biggest one of the weaknesses is that it's a drug-sponsored trial. And I think anytime you have a study that's sponsored by a drug company, you always have to, be a bit more cautious about interpreting the findings. So Taysir says we can give it for all patients as prophylactic above 40 years who had a risk of cardiovascular disease. Well, I don't think I would necessarily change my practice based on this one study, and I think I'm personally I would like to see a bit more evidence before I would take that on and apply it in clinical practice. One of the second main weakness of the study is that they stopped the study early. So whenever you stop a study early, you can overestimate the treatment effect. So what can happen is that you start the study and you get events, in one arm of the group. So, for example, the aspirin arm may have got a lot of events. Now, if you carry on, if you stop the study at that stage, you can say, oh, look, there's a big difference between the aspirin group and the Rivaroxaban group. But if you carried on with the study, it is very possible that the Rivaroxaban group may catch up later on. So they may start to get the events, as time goes on. So if you carry the study on to the full 3 to 4 years, while those the differences seem to diverge, they may converge again. So it may actually they may catch up later on, if that makes sense. So I think that's one of the biggest problems of the study, is that if you stop a study early, you can overestimate the effects of the treatment. So if you looked, although statistically there were statistically significant differences between the groups, if I go back to this graph here, on the right hand side there seems to be quite a large gap between the blue and the black, and similarly here. But actually they've actually look at the scale they've used here. So the scale here is between 0 and 0.1. So the absolute difference between here and here is literally 0.02% difference in absolute difference. So if you look at this graph, and if you look, this is 100%. So this is, if there's 100% risk, and this is a 0% risk, if you look at this graph here, you can see it's just very, very, the differences are very, very, very minute. Although statistically it's significant, the absolute differences are absolutely tiny. So I think that's something that needs to be taken into account. Also, the female patients, again, there's a recurrent theme in cardiology studies that females and non-white patients are underrepresented. There seems to be just predominantly males in studies. So whether or not we should be using this treatment in females is to me is not 100% clear based on the study. The other weakness is that it was a composite outcome. So a composite outcome means that you've lumped a number of things together. So they've looked at cardiovascular death and MI and strokes and added them all up together and said, let's count all of these as the primary outcome. So whenever you use a composite endpoint, you have to always be careful, because when you look at each one individually, there may not be significant differences. In the study, in the discussion, they didn't mention anything about mechanisms. So I don't understand how you can have a lower cardiovascular death, but similar rates of MI, similar rates of heart failure. Again, there seemed to be an effect a greater effect in East Europe and Asia. I'm not sure why there should be such a difference. A very strange finding was that patients who had Rivaroxaban and aspirin had less intracranial bleeding compared to Rivaroxaban alone. I think that was quite interesting. I don't know whether that's a real finding. The other weakness is that they did their power calculations based on the efficacy outcomes rather than the safety. So I think you always have to be careful when you're interpreting that. So Iman asks a question, is there an ethical obligation to stop the study at the stage when they did? And the answer to that is a great question, and the answer to that is yes, there is an ethical obligation. And I think it's a very difficult decision to make. And I think what they did, which was quite good, is that they'd pre-specified. So they'd set it up in such a way that they'd written, if, in the event that we find these differences, then we should stop the study early. So I think from a patient safety perspective, it's something that has been put in place to protect patients. And I think that's a great point there, that whenever you do research in the modern times, we have to consider the ethics, and we have to consider patient safety. And I think that's a very good question. So often in a lot of studies, they do stop early, particularly when they see big differences in benefit, because if there's a big benefit in one treatment, then it becomes unethical to deny another patient that treatment. And similarly, if once one group are getting more harm, then it's unethical to keep randomizing patients to something which is going to cause harm. But at the same time, from just purely from a scientific perspective, if you don't let the study run to its end, your findings may be inaccurate. So as I said, it is very possible that if they carried on following patients up 3-4 years, they may find that actually the cardiovascular events in the aspirin group may start to slow down, and the cardiovascular events in the Rivaroxaban group may catch up. And I think one of the problems with this type of when you're stopping studies early is that what needs to happen really is we need more evidence. So I think we need more studies to look into this, and to look into in more detail, and to see whether or not another study can reproduce and have the same findings as this study. Because there have been occasions in the past where people have changed their practice based on one study showing a huge difference, but actually later on, when you repeat the studies, you'll find that actually there's not such a big difference as initially was thought. So the conclusions, so my personal conclusions for this paper is that this is a good study, a large randomized control trial, and it supports the use of Rivaroxaban 2.5 milligrams twice daily in addition to aspirin for secondary prevention in cardiovascular disease in a selected group of patients, and patients who are white, male, no prior stroke, and who have a low bleeding risk. I think more evidence is needed to confirm their findings and to clarify exactly what the bleeding risks are in patients who are taking Rivaroxaban, and also more studies are needed to try to understand what is the mechanism of a cardiovascular death reduction with low dose Rivaroxaban. How does it act? How does the Rivaroxaban affect your cardiovascular death? How does it reduce cardiovascular death? And I don't think that's fully understood. And again, you always have to bear in mind that this is an industry-sponsored study, so you have to just bear that in mind before applying the results in clinical practice. So I've concluded my talk, and I was wondering whether anyone has any other questions. Okay, so Amna asks about what about the number needed to treat and the number needed to harm? Do we need to calculate it for the purpose of the journal club? I think if you have the time to go through it, and you want to practice it, you want to practice your your statistics, I think it's a very good idea to do that. But for the purposes of a journal club, you don't necessarily need to actually calculate it when you're presenting it. you don't, but it's useful. It may be useful for yourself to, and if you've done it, it's certainly not a bad thing to do, but you don't have to do it. Any other questions? Okay. So Maha asks, do we need to stop Rivaroxaban before any surgical procedure? If yes, do we need to bridge it with IV heparin, and for how long? Okay, so this is a very good question, and in fact, there is an article by the European Society of Cardiology who answer this question about what to do with not just Rivaroxaban but all of the non-vitamin K oral anticoagulants, and when you should stop it. So the first point is that you don't always need to stop Rivaroxaban, and it will depend on the procedure. And the procedure, it depends on the bleeding risk of the procedure. So, for example, in cardiology, when we do coronary angiography or percutaneous coronary intervention (PCI), we don't actually stop the Rivaroxaban. We carry on. We continue with the Rivaroxaban. We continue with the non-vitamin K oral anticoagulants. And that's because we would perform the procedure via the radial artery, which carries a significantly lower risk of bleeding than from the femoral artery. So we wouldn't do the angiogram femorally, but we would do it via the radial artery. So the first point is it depends on the surgical procedure. If it's a very minor procedure, you may not need to stop it. Secondly, if you were to stop it, then in terms of how long would you need to stop it before the procedure? So this depends upon the renal function. So with Rivaroxaban, it's cleared in the kidneys. So if you were to stop the Rivaroxaban and you have normal renal function, then the half-life is sort of less, around eight hours or so. So you could, and so Rivaroxaban is a once daily drug. So if they'd had the Rivaroxaban this morning at 8 o'clock, then you could do the procedure by the following day, within 24 hours. If you're a bit more concerned, you may make that sort of 48 hours. If the patient has renal impairment, then that would need to be extended, that period of time. So you may want to stop it 72 hours at least beforehand, so through about 3 days, maybe even 4 days. In terms of do you need to bridge it with IV heparin, I've not known any surgeon who would do that, and it's not there's no recommendations for bridging with IV heparin. So you have to remember, what is the indication for the Rivaroxaban in the first place? So if the indication is that they've got atrial fibrillation for stroke prevention, what I would look at is their CHA2DS2-VASc score and see how high risk they are. And if they're very, very high risk of a stroke, then I'll try to minimize the interruption to the Rivaroxaban as much as possible, and to try to restart it as soon as possible. So I wouldn't necessarily bridge with IV heparin. But again, if you look at that, there's an article about this in the European Society of Cardiology about what to do with the anticoagulants. Any other questions? Hashim Asir, can you give us a comment? Yeah. So Hashim is a fellow cardiologist, so It'd be nice to get some of his comments on the study. So, thank you everyone for your comments. Okay, so Ahmed says, thank you for the information. I have two questions. What is factorial design study? Do you think that the fact that the study sponsored by Bayer might be an issue? Okay, so I think to answer the first question, the factorial design, this is if you look at this, the methods here. So this is 3 by 2 factorial. That's what it means. So 3 by 2. So they've got 3 groups. So the first group is the patients take Rivaroxaban 2.5 plus the aspirin. The second group, they take Rivaroxaban 5 and the aspirin, without aspirin, so Rivaroxaban only. The third group is they've got just aspirin alone. So these are the three factors these are the three groups that they're looking at. The factorial design, the 3 by 2, means that they, in addition to that, they also randomize patients to pantoprazole and no pantoprazole. So you can see here, you've got Rivaroxaban 2.5 BD, aspirin plus pantoprazole 40 once daily, and in this group they've got Rivaroxaban 2.5 BD, aspirin, but a placebo pantoprazole, so no pantoprazole. So that's the factorial design study. And in terms of do you think the fact that the study is sponsored by Bayer might be an issue? And Bayer is a pharmaceutical company that manufactures Rivaroxaban. So yes, I think definitely you have to take that into account, that this study was sponsored by them. Clearly, they would want the study to be successful. They'd want to show that Rivaroxaban is useful. But again, obviously, all pharmaceutical companies, they themselves are bound by ethics as well. But again, so you just have to take things into consideration in terms of, for me, one of the things that I think about is the fact that they've got the way that they've set up the efficacy and safety outcomes. There's so many different ways you can set this up, and wonder what, and this net clinical benefit. I mean, I think you just have to be very careful with the way that the drug companies set up their studies, because often it's set up to show success. Basically, it's set up to be successful. Okay, I think if there aren't any more questions, then I can stop the live video, and I'll be happy to answer any additional questions that anyone might have. Okay. Assalamu alaikum.